First speaker, she'll be speaking on diagnostic consideration of benign and malignant pathologies.
Thank you so much, ma'am.
Dr. Simarpreet, she is professor and head, Department of Oral and Maxillofacial Pathology, Genesis Institute of Dental Sciences and Research, Firozpur.
Switch on some lights, please. Switch on some lights. That's it. Thank you.
She has numerous publications in various national and international journals and has given scientific deliberations at various conferences. Her field of interest is epidemiology of oral cancer. So, I present Dr. Simarpreet Sandhu for her first lecture.
Thank you, ma'am. Ma'am has been my teacher, and now also a few of the cases you'll see, I've been running to her for opinion. Thank you so much. I am really grateful to Dr. Sumit Sandhu, who's been my teacher, mentor, and a relative, who has been a constant source of inspiration. And today I'm standing here to deliberate on diagnostic considerations of benign and malignant pathologies of oral and maxillofacial region. Oral and maxillofacial region hosts a wide variety of cysts and neoplasms, and many lesions exhibit characteristics similar to those of less aggressive and or more destructive pathologies, and clinicians must understand the anatomy of tissues inherent to each area of cavity as well as pathologies of different lesions. Now, diagnosing lesions of oral and maxillofacial region is necessary for proper management of patients, and clinical differential diagnosis is very important, and after that we reach to a definitive diagnosis. These are the four diagnostic columns: clinical, radiological, histological, and ancillary techniques, which are taking a main stage now. Oftentimes, the history of the patient will immediately focus on differential diagnosis and give a clue as to whether the lesion is benign or malignant. The duration of the lesion is important because it can provide a clue as to its natural history. Benign tumors may be extremely slow growing and may present for years. Now, this is a benign which shows an intact skin, it's an expansile growth, and it's slow growing, and there's a normal surface coloration, which is not the case in case of... I need to go back, I can't configure this. I need to go back on the slide. Smooth, and this one is irregular. There's a surface discoloration, and this one is normal skin color. The rule of thumb is that if the lesion is present for 2 weeks, it's infectious. If 2 months, it will be malignant, and 2 years, benign. But there are always exceptions. Just because this growth is slow growing, however, doesn't mean it is benign. Some malignancies exist that are also slow growing. For example, we have polymorphous low-grade adenocarcinoma and adenoid cystic carcinoma. This stresses on the importance of biopsy and evaluation of the lesion regardless of duration. Malaise, fever, night sweats, and weight loss are also important signs. A patient presenting with these symptoms and a swelling on the neck with lymph nodes greater than 1 centimeter may raise a suspicion of lymphoma in an elderly patient or leukemia in a young one. So in the inspection, like I talked earlier, the benign lesions are normally smooth, and in this, the exceptions are highly malignant varieties. And cysts and nevi are also smooth, and earlier malignant salivary gland tumors are smooth. In the rough surface, we have papillomas and keratoacanthomas and verrucous carcinoma. Now, this is a pebbled, warty appearance. On palpation, if a mass is bound to skin or mucosa, the possibilities are there's fibrosis from the previous inflammation, an infiltrating tumor, a malignancy, or a malignancy that originated in the loose connective tissue. Now, if the consistency is soft, chances are it's Wathen's tumor, neurofibromas or fatty tumors, but liposarcomas are also soft. And rubbery, you have lymphomas, myomas, myoblastomas, and aneurysms. Firm, you have osteosarcomas, chondrosarcomas, and malignancies of the soft tissues. And in the bony heart, you have exostosis and osteomas, chondromas and chondrosarcomas. In the age-related factors, in the benign, you have, if the child is less than 16 years old, then the chances that the more common tumors are hemangioma, and the malignant rhabdomyosarcoma is more common. In a young adult of 16 to 45, hemangioma is common, and in this case, synovial sarcoma is more common. So age also has a very important role to play. Older adults, lipomas and myxomas, and in the malignant variety, you could have liposarcoma and leiomyosarcomas. Location in the oral cavity. In the gingiva, the most common tumor could be a peripheral giant cell granuloma. In the floor of the mouth, it could be a dermoid cyst or a salivary gland tumor. Lip and buccal mucosa, it could be a salivary gland tumor or a mucocele. On the tongue, granular cell tumor and salivary gland tumors are common. On the hard palate, salivary gland tumor and mesenchymal tumors. And soft palate, the subepithelial lesions in this area have a higher than average chance of either recurring or being malignant. Now, this is a typical example of a benign soft tissue tumor. It's better defined and circumscribed and has a very slow growth rate, and it's surrounded by a fibrous capsule, and the lesion was movable, and this was actually a case of osteolipoma. The malignant soft tissue tumors, when encountered, should be differential diagnosed from the reactive lesions. A challenge in different diagnosis of soft tissue enlargements is the distinction, and malignant neoplasms are persistent and progressive, while reactive fluctuate in size and easily regress. Reactive are soft tender lymph nodes, and metastatic malignant neoplasms are firm and tender lymph nodes. Salivary gland tumors, again, they have some thumb rules. The most common site for salivary gland tumors is rotid, and a relatively low percentage of these tumors are malignant. But the frequency of malignancy in the submandibular gland is almost double. Tumors of sublingual glands are rare, however 70 to 90% of these are malignant. So excluding the rare sublingual gland, it can be stated that the smaller the gland, the greater is the likelihood for malignancy. As for these are the potentially malignant lesions. These are basically the epithelial pre-malignant lesions, and you have homogeneous leukoplakia, nodular leukoplakia, proliferative and spectral leukoplakia. And these are the epithelial malignant pathologies, which vary from, this is verrucous carcinoma, the squamous cell carcinoma, which you frequently encounter, and a basal cell carcinoma. After the clinical, you need some clinical laboratory tests to as ancillary techniques, and clinical findings may indicate the need for diagnostic clinical tests conducted in pathology laboratory. These tests are used to evaluate blood chemistries. For example, in multiple myeloma and Paget's disease and hyperparathyroidism, immunological reactivity, urine analysis in multiple myeloma, you have Bence-Jones proteins, microbiology and genomic assays. I won't go into the detail because I have to discuss all the techniques, and I only have about 30 minutes. Now, this is a case history. The 3 cases I'm going to show, which stresses the importance of the knowledge of the clinical tests. Now, this was, I only received a tissue and Dr. Madhu Manjari helped me on this case. A 55-year-old male, provisional diagnosis was a squamous papilloma or a verrucous carcinoma. It was a very tiny bit, and the incisional biopsy was taken from a growth from forehead extending from buccal vestibule. OPG, according to the surgeon, showed no signs of resorption, but the lesion grew rapidly after the surgery. But to our amazement, what we saw was proliferation of sheets of small round cells, and man remembers the case. And this is what we saw, and a very prominent crush artifact. And the differential diagnosis was first infectious, second small round blue cell tumors on such a small piece of tissue. It was very scary to commit, and an adequate immunohistochemical panel is needed. After the patient was referred to PGI, and Dr. Vidyarathan saw him, and he asked me that is it Kaposi sarcoma, and then when he said it's Kaposi sarcoma, the patient had hidden the fact that the patient was HIV positive for the last 2 years. So then it made all the more sense that the patient had basically a non-Hodgkin's lymphoma. So it's very important that the history of the patient is extremely important, and the status if hidden can really lead a lot of problems for the pathologist and for the surgeon. Another case of swollen gums in the right lower region, the swelling was firm, and the clinical impression was gingival hypertrophy or denture-induced fibroepithelial hyperplasia. Now this is what we got. We got non-caseating granulomas and giant cells, and this was the features were suggestive of granulomatous gingivitis, and special stains like GMS, PAS, and ZN were done to rule out fungal and acid pass bacteria. But after searching for signs and symptoms of local and systemic granulomatous disease, the patient was advised tests, and the barium meal enema showed ulceration, inflammatory changes, and narrowing of right colon. Hence, the patient was unaware, but from the incisional biopsy, we made a diagnosis of Crohn's disease, and then the patient was referred to the medical physician. Another case of 56-year-old male, patient complains of pain and burning sensation, and detailed history was suffering from asthma, and 3 years back was diagnosed with aspergillosis. Provision was a non-healing ulcer, and the patient had hidden the fact that the patient had aspergillosis. And differential diagnosis was a squamous cell carcinoma and oral tuberculoid lesion. Now this is what we got, and it was basically a granulomatous reaction. Special stains did not show any hyphae, and this was the culture on the second day. And we had a fruiting body, and this was done, the culture was sent to GMC at Precoat, and they have done it to specification, and it was aspergillosis niger. After the patient was asked for x-rays and all, it was then he said that yes, he was suffering from aspergillosis. So sometimes when the patient hides a very important part of the clinical data, it does lead to a lot of issues with diagnosis. The radiological investigations, I'm not an expert, and this is the part I'm really scared of. Imaging is not always expected to provide a specific diagnosis, but it helps to narrow down the diagnosis. And these are the few x-rays that are needed for jaw lesions like panoramic and cone beam CT. Joint facial tumors, you have panoramic CT scans, radio isotope scans, and nuclear magnetic resonance images and PET scans. And for vascular lesions, it's angiography. Now, to keep it very basic, like the periphery and the shape, like I said, they're slow-growing, the benign pathologies. So there is formation of additional internal structure, and borders are relatively smooth, and they may be radiolucent, radiopaque, or mixed. Now, pressure from the neighboring structures, displacement of teeth, and root resorption may be common. Now, for oral malignancies, borders are ill-defined, uneven extensions, irregular shape. Internal structure is mostly radiolucent because they don't produce bone until and unless it's an osteogenic sarcoma, a metastatic breast, or a prostate lesion. As far as the effects on oral structures, surrounding structures is concerned, teeth appear to float here, and there's destruction of the cortical borders. Root resorption, you can see here, destruction of the internal trabecular structure, and displacement of the developing teeth. Now, these are the 2 x-rays of squamous cell carcinoma and osteomyelitis, which both have the similar findings. Because of the destruction of cortex, they have floating teeth. This is an overview or the summation of the diagnostic imaging, and we can see that according to the age, even if they're dividing according to the age, you still have a lot of things which are common. In a 40-year-old, it's metastasis myeloma. If it's well-defined, metastasis myeloma. If it's ill-defined and sclerotic, again, metastasis. And in all ages, infection. So we need to go a step further. Like, these are the multilocular radiolucencies, and they all had different histopathological findings. Now, given the wide range of pathological features but similar imaging findings, familiarity with secondary imaging findings is crucial. And if an aggressive growth pattern or malignant periosteal reaction is identifiable, another imaging modality like CT or magnetic resonance imaging is needed. And an MRI is important for defining the extension of tumor before biopsy. Now, CT is superior to MRI for assessment of mineralized structures, especially cortical integrity matrix mineralization and periosteal reactions, and small radiolucency of the cortex, localized involvement of soft tissues, and thin peripheral periosteal reaction can be best seen with CT. CT helps in eliminating superimposition of structures, and MRI is helpful for evaluating lesions that represent a differential diagnostic dilemma between benign and malignant lesions before the biopsy. For example, aneurysmal bone cyst on an MRI displays fluid levels, and multiple myeloma, the whole body MRI scans are suitable for demonstration of tumor burden. Now, this is the overview of the imaging appearance of common benign tumors and the common malignant tumors. But rendering a diagnosis of benign or malignant in oral environments based solely on clinical and radiographic examination is insufficient to ensure the delivery of proper treatment. Additionally, when suspicious lesions are encountered, histopathological examination should be part of the diagnostic process. And this was a study done by Dr. Tatley et al. And histopathological diagnosis did not match the clinical diagnosis in 6.7% of the cases. And clinicians excelled in diagnosis of benign and precancerous lesions in a clinical setting, and the detailed discordance characteristics of each specific lesion should be considered during oral pathology practice to provide early detection. Histopathological examination is the gold standard in diagnostic pathology to confirm the clinical diagnosis, and the pathologist's approach to the distinction between benignancy and malignancy is critical, as treatment of benign neoplasms is generally conservative, whereas malignant may warrant more aggressive management. The first thing, we have fine needle aspiration cytologies. That's an established tool, and in this you have moderately to high cellular specimens, could be sarcomas, and irregularly contoured and variably thickened nuclear member is the other feature, and they are more sparsely cellular as compared to benign mesenchymal lesions. Now, this is the classification of soft tissue lesions on the basis of fine needle aspiration biopsy. And in a critical review of role of fine needle aspiration cytology in soft tissue tumors, the authors said that they were able to distinguish benign from malignant in 94% of patients. And as in the experience of many individuals, the area of greater difficulty was spindle cell neoplasms, followed by lipomatous tumors. But fine needle aspiration has certain disadvantages. There's dispersion of individual cells and loss of recognizable diagnostic patterns. And there may be even more difficulty in distinguishing benign cellular lesions from low-grade sarcomas. So we come to the gold standard, the incisional and the excisional biopsies. Now, pre-treatment biopsy of the primary tumor is essential for most patients presenting with soft tissue masses. In general, any soft tissue that is enlarging greater than 5 centimeters should be considered for biopsy. The preferred biopsy method should be the one that is least invasive. As excisional is done for smaller lesions, the incisional is done when you have was found to have limitations in assessment of oral leukoplakia. Clinicians must be conscious of the possible underdiagnosis from incisional biopsy, and multiple biopsies should be taken, and the desirable biopsy is usually deep and narrow that has some amount of normal tissue with it. After we've biopsied, we receive it on our grossing table, and this is a gross appearance of a dentigerous cyst. And you can see that the cyst was attached at the neck of the tooth. And another, this is basically the correlation of radiographic findings. This is an AOT, which is a benign odontogenic tumor. And here is the tooth, and the gross, the tooth is here. This is the cystic cavity and tumor, and this is the tumor periphery. So a gross says a lot when you receive it on your table. Another case from our archives is, this is a typical gross of Wathen's tumor. You can see, again, you can correlate it with the histopathological findings. This is the connective tissue. These are the cystic spaces, and this is the sporting stroma. Another gross of giant cell tumor, and you can see that the hemorrhagic areas and necrosis is also there in the tissue. Microscopic examination, the first and foremost important step in reaching a correct diagnosis, is careful scrutiny of the conventionally stained, that is H&E stained sections. And useful features that you see are size and depth of the lesion, the relation of the lesion to the underlying connective tissue, and the nature of the borders. Here you have borders which are pushing, and here you have ones which are in trouble. The patient is in trouble. Once satisfied that the reactive lesion can be excluded, the pathologist is justified in proceeding with analysis of neoplasm. At low power, you're usually stuck with architectural pattern, the appearance of cells, and the characteristics of the stroma. These are basically the patterns. Now, differential has a biphasic, osteosarcoma has biphasic pattern. Malignant fibrous histiocytoma has toriform, and there are alveolar or round cell pattern in rhabdomyosarcoma, and this is palisading in schwannoma. These are very, very diagnostic. And you have spindle cells, whorled pattern, and diffuse round cell pattern. On a low power also, what you can discern is there's a distinct and intact capsule. You can see that, that's a tumor, that's a normal salivary gland. If it lacks encapsulation, chances are that this is on low power only, you know that this could be something more vicious. The malignant tumors invade nerves. Now, this is typically called the perineal invasion when the tumor swirls around. This is the case of adenoid cystic carcinoma. The benign tumor, the tissue structure resembles normal, but this is an altered tissue patterns of liposarcoma. There are no necrotic areas in benign, but you have occasional areas of necrosis in malignant. When we come to higher power, we see the cytological features are changed in case of cancer, and you have large variably shaped nuclei, many dividing cells, variation in size and shape, and loss of normal features. Also, the degree of cellular differentiation, like you can appreciate lipoblasts, which are sharply defined. They have these are intracellular droplets of lipid, and you have one or two nuclei, and this is the rhabdomyoblast with its striations. One thing that is very, very important, especially when we talk of sarcomas or any malignant tumor, is the mitotic counts. The number of mitosis per high power field, like you have a lot of mitotic figures here. Also the ones that are abnormal, the tripolar and the quadrupolar, they surely are indicating something malignant. Now, when you formulate a final diagnosis, in case of most pathosis is provided by oral pathologist who evaluates a biopsy in the light of all the clinical and radiological data. And it is worthwhile that there should be a close correlation between the surgeon, the oral medicine department, and the pathologist, because everybody provides a different insight. But in some instances, the microscopic picture is so equivocal that the pathologist must depend heavily on the accompanying clinical signs and symptoms for establishing the diagnosis. Now, we're going to show you the 3 cases where we thought of something else but turned out to be something entirely different. A 40-year-old female, and she had swelling in the left lower back region, and there was swelling of the mandibular region, and history of previous surgery. Now, this was very important, which we ignored it earlier. We took it for granted that this must be the recurrence of the same tumor. We did not have the report, but, and she never, this was also important, she never reached for regular follow-up, and she never went back to the operating surgeon. We did not have the histopath report, but this was the lesion, and because the earlier history, she remembered something like, she used the word Risoli, so it was something to do with odontogenic lesion. So we proceeded with the thought that this is an odontogenic pathology. And she did not have any histopathological reports. We made a differential of OKC, ameloblastoma, and osteomyelitis. But to our surprise, again, on a table, what we found was it was entirely different. What we had was a foreign body, and it had elicited a huge inflammatory response. And we had this cellulose, a lot of giant cells, more giant cells, and this was cellulose. So we called it Gossipiboma, and you have instances of this entity in abdominal area or where the gauze is left behind. In case of this patient, the patient never reported back, was given a packing, and since the patient didn't return back for 2 years, the retained gauze has elicited a granulomatous reaction. When the gauze was removed, the patient started healing, and the OPG showed extensive newborn formation and restoration of the bony contour. So in presence of limited tissue sampling, the initial testing modalities including fine needle aspiration biopsy or incisional biopsy, it is often not possible to differentiate a benign from a malignant tumor. The diagnostic difficulties arise from the absence of needle or incisional biopsy to determine whether infiltrative growth is present or not. Now, this is a case history of a proliferative soft growth. Patient suffered from unicystic ameloblastoma 2 years back, and this was the resection that we received. And this case was diagnosed as ameloblastic carcinoma. Another case, this is a case of 25-year-old female, and provisional diagnosis was cemento-ossifying fibroma. So this was, the gross was gritty and hemorrhagic, and what we got was focal cementosseous dysplasia. Another case, which was 27-year-old male, swelling, and provisional diagnosis was cemento-ossifying fibroma or cemento-osseous dysplasia. And yes, it had typical ginger root appearance, and this was a florid kind of cemento-osseous dysplasia. Now, most of the times what happens, we cannot identify, H&E is like X-rays, and we, the pathologists, are unable to identify because the cells look very similar and they share it with many more entities. That's where histochemistry comes in, especially for identification of fast-positive diastase-resistant crystals and epithelial mucin. Now, these are the two cases we're going to show about. This is a patient who had a painless swelling in the lower back tooth region, and this was the secretion and this was the cystic lining. And this is what we got, a lining supported by connective tissue stroma, and also there was evidence of mucinous cells. This was mucicarmin, and this was the control from the stomach villi, and these were positive for mucin, and a diagnosis of glandular odontogenic cyst was made. A 30-year-old male, provisional diagnosis ossifying fibroma. We just received a tissue from Ganganagar, and this was what we had on a table, and this is a case I've still not been able to solve till now. What we had was fibrous tissue, and we had some areas which looked glandular. These look like polygonal cells, epithelial cells. These look more like clear or salivary, mucinous, I don't know. And this is what we were talking about. Was it amyloid? I have no idea. There were also some calcifications. But when we did histochemistry, these were positive for mucicarmin. Now, if you were thinking it ought to be a clear cell CEOT, should not have been positive for mucicarmin, and was negative for combo red. So it couldn't be amyloid. This is a case which will be now sent to immunohistochemistry because this is still on our table and we've not been able to diagnose it yet. Immunohistochemistry, you need a panel of antibodies to differentiate carcinomas, melanomas, sarcomas, and lymphomas. And immunohistochemistry is important to, if not obligate, for workup of small round cell tumors. Now these are just very briefly, I've put it here, is like basic antigen groups for sarcoma immunodiagnosis. These are screenal panel for undifferentiated round cell tumor, monomorphic and epithelioid, because normally when you have very similar looking tissues, there's normally a panel that is chosen, and this is to discriminate a carcinoma from epithelioid sarcoma and epithelioid angiosarcoma. So you have a CD34, CD31 and FL1. So just to show you, in the end, 4 cases to conclude about the importance of immunohistochemistry, that we could solve 4 cases in our department. This doctor, I think Bimal Kalia will relate to this case. This was operated with Dr. Khanna in BRS, and he was the operating surgeon along with, I think, Dr. Sodi's case from Fleetcoat. So this was a patient with a 60-year-old male and rapid growth on the interior maxilla. The growth was painless, and mass was obliterating the interior nasal chamber, and the interior maxillary alveolus was completely destroyed, and thought of an aggressive malignant neoplasm. And thought of salivary gland tumors in the differential, a Kaposi sarcoma because of bluish discoloration and palatal position, other mesenchymal tumors, squamous cell carcinoma or melanotic melanoma. This was the gross, and I got half of the gross. I think the other half was sent to Tata Memorial, if I'm not mistaken. And this was what we got, sheets, of spindle cells. So, and a lot of hemorrhage, and we had tumor masses composed of elongated spindle cells ranged in interlacing bundles and interweaving fascicles. But we also had a lot of pleomorphism, And immunohistochemistry had to be carried out because there are a lot of malignant spindle cell lesions, and you needed to first to rule out spindle cell carcinoma or malignant melanoma, and also to differentiate the cell type, whether it's fibrosarcoma, leiosarcoma, or so if the tissue is positive for vimentin, it is certainly a sarcoma. And then you had smooth muscle actin was focally positive, and this was the tumor profile. So this turned out to be a pleomorphic leiomyosarcoma, grade 3/3 Coinder, and this was a morphological variant and usually defined in association of areas of undifferentiated pleomorphic sarcoma which shows smooth muscle differentiation in areas. Another case we solved with the help of IHC was a 23-year-old male and had early loss of teeth, and there was a crater-like defect. Another site in which there was similar loss, and this was the X-ray, and you could see the punched out loss of tooth structure. And this was a differential diagnosis: multiple myeloma, osteomyelitis, aneurysmal bone cyst, and eosinophilic granuloma. And what we found was sheets of eosinophils with, these are all eosinophils, the granular cells are eosinophils, and we had this typical coffee bean cell, which is the Langerhans cells. But just, even if you see this, you cannot label the patient as eosinophilic granuloma till and when you confirm the diagnosis of LCs for S100 and CD1. So this was carried on, and the tumor came out to be strongly positive for CD1A and S100, thus confirming a diagnosis of eosinophilic granuloma. Another case in which 70-year-old male had a history of proliferative growth and a history of tobacco chewing and obliteration of lower vestibule, and this is what we got on our table. And we received an R&D, and we had atypical cells invading connective tissue stroma, which exhibits plasma lymphoid infiltrate, and round atypical cells and with prominent nucleoli. And we were thinking of, we wanted to know whether these were atypical endothelial cells and were they piling up the lumen. And we kept thinking of it as an angiosarcoma. But the differential diagnosis was acantholytic sarcoma, angiosarcoma, and rhabdomyosarcoma. We advised immunohistochemistry, and for pancytokeratin was positive, which meant it was an epithelial tumor. It was not a sarcoma, it was not an angiosarcoma. And so we came to the diagnosis of acantholytic squamous cell carcinoma. Based on, and I want to stress, this was based on clinical, histopathological, and immunohistochemical analysis. Last case is a 60-year-old male with chief complaint of growth in the right lower left jaw. And we had sheets of haphazard cells which were ranged in atypical cells of variable morphology. And epithelioid or focal spindle cells, I think it's numerous mitosis. And the differential was a poorly differentiated malignant tumor, amelanotic melanoma or spindle cell carcinoma. We again ran, and whenever you have a tissue which is positive for vimentin, it means it's a sarcoma. So this was certainly a sarcoma, and it was positive for protoplanin and EMA and pancytokeratin. So this came out to be, based on the above features, it was epithelioid angiosarcoma. So does it mean even if something is diagnosed as a squamous cell carcinoma on the incisional biopsy or whatever, it's always worthwhile to rake your brains, go back to the clinical diagnosis, consult with the oral surgeon, do the ancillary techniques, and come to a definitive diagnosis, because treatment varies. So it is very important that during the vigilant intraoral examination, a high level of knowledge-based suspicion, as well as conducting a thorough head and neck cancer examination, are important for establishing correct diagnosis of lesion, hence ensuring a proper prognosis for the patient. And successful management of the patients can be accomplished by dental health providers with step-by-step approach to gather information and apply it in a systematic manner. These are the potential future diagnostic techniques. We have worked a bit with RT-PCR and in situ hybridization. PCR and tissue microarray is what we are planning to work on in the department. And the data has come from, I acknowledge my department, the Department of Oromaxillofacial Pathology. This is Genesis Institute of Dental Sciences and Research. This is the team. the postgraduates who work from morning to evening. Thank you so much for your patient listening.
Open for discussion.
Anybody wants to ask any question? I think no questions.
Thank you so much.
So I would like to stress upon something, that is, as far as pathology, oral pathology is concerned, it is these days it has become very important that as we are in the era in which immunohistochemistry and molecular biology and molecular genetics is there, we must send the cases for immunohistochemistry. A few years back, when immunohistochemistry was not there, we used to label malignant mesenchymal tumor, and the treatment used to remain one only. But now, with the advent of the immunohistochemistry, we can classify many tumors, especially the undifferentiated tumors, and then we can give the treatment accordingly, and the patient is benefited. So I do remember the case you brought to me, and I told you to give it as small round cell tumor and go for immunohistochemistry because that appears to be, it could be NHL.
Patient had written the status of HIV.
Yeah. So I still remember, I told her to go for immunohistochemistry and it could be NHL, and it turned out to be NHL. So thank you very much. Thank you, Doctor.
Madam, I'd like to ask something for the general practitioners. Like our young budding dentists who are practicing in the field, usually a surgeon knows whether to take a biopsy or go in for an exfoliative cytology or something like that. But for a general practitioner, the practitioner who is sitting in a small town, he is usually confused with whether to go in for an exfoliative cytology or to go in for a biopsy or something else. So what do you recommend for a general practitioner? Like, what should be the line of treatment when he comes across to a oral maxillofacial pathology?
Dr. Raman, that's the second part of my topic, which Dr. Smith's interested me with. That is basically screening and going on to the, at the general base level. That will be talking in that case. But exfoliative cytology is something I don't think so that that should be done by an expert. And even for the incisional biopsy and all, what I believe is that whenever any suspicious lesion is encountered, it's always better to consult, refer, and at least be in touch with a surgeon or with an oral medicine expert, because just cutting, sometimes they cut from the infected tissue and all, it doesn't help. It was always worthwhile to refer and counsel. Till now, any case that comes on my table